Good evening, everybody. We're just going to go ahead and get started with the intro slides as people have a chance to log in. I just want to make sure that Dr. Furlan gets lots of time to share all her good work with us. So welcome to our September PCN Pain Rounds. We're going to be having a presentation from Dr. Andrea Furlan talking about activity with people with pain. Just go through our land acknowledgement. On behalf of the PCN Pain Rounds Planning Committee, we wish to acknowledge the traditional homeland of the many diverse First Nations, Métis, and Inuit people whose elders walked this land before us, and those persons with whom we share this great land with today. Our committee is based on the traditional territories of the people of the Treaty 7 region in southern Alberta, which includes the Blackfoot Confederacy, which comprises the Siksika, Piikani, and Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, including the Chiniki, Bearspaw, and Wesley First Nations. The city of Calgary is also home to the Métis Nation of Alberta, Region 3. We are grateful to work and live upon this territory together and for the means to learn from all of the traditional peoples of these lands. May our care reduce their burdens and help light the path towards a brighter future for us all. Just a reminder that this Friday is the National Day for Truth and Reconciliation, September 30th. This program does receive in-kind support from the Alberta College of Family Physicians in the form of webinar infrastructure. Thank you so much, ladies, for your help. Here is a list of our planning committee. We have representation from most of the PCNs in the Calgary region. So we have Jen, Dr. Nixon, Kylie, Matt, Dr. Caudry, Dr. Montgomery, myself, and Corey. The background for our primary care chronic pain rounds open to anyone, but we've really designed them for primary care teams primarily. We plan them about 6 times a year. We've had a few special sessions in between. The focus is on chronic pain and issues common to people with pain. We rotate different weekdays. They usually start at 5:30 and go to 6:45, and we do them via Zoom. If you've been with us before, welcome back. And if this is your first time, welcome. We would really appreciate your feedback. There will be a link in the chat box towards the end of the session, and we'll also be sending an evaluation form throughout the week. That really helps us to improve our programming, and we really appreciate your feedback. If you have any technical or logistical questions, if you could include those in the chat box. Otherwise, if you have questions for Dr. Furlan, if you wouldn't mind using the Q&A function, we would really appreciate that. Here's just a note of our upcoming rounds. So we're going to be doing another one in November. Things we thought we knew about pain medications, a new peer simplified guideline for pain. Highly recommend this one if you haven't seen the guideline already. And we'll have Dr. Koronik and Adrienne presenting. And I think Dr. Montgomery will be in the background. We also have the role of common mental health presentations and chronic pain coming up in January with Dr. Berg and Dr. Young. A plug for tomorrow, in case you haven't already signed up for the CMN Pain Rounds tomorrow evening, or their presentation story. They are doing Unraveling and Treating the Epidemic of Pain in Children. That one should be amazing. Starts at 7 tomorrow night. So if you're interested and you haven't had a time to register, the registration link is in the chat. We'll just do a quick poll here so Dr. Furlan can see who's in our audience. The first one that pop up will just be discipline. Awesome. So far, family docs and pharmacists. Awesome. Okay. And then we'll just pull up our other one here to let us know what PCN or in location from the province you're coming from. Awesome. So you got a good balance. Welcome, everybody. That's amazing. The learning objectives for today's talk will be, oh, we got our poll still there. Awesome. That looks great. Thank you, everybody, for coming. So be to help a patient understand when it's safe to begin an activity program, educate a patient about the ways that activity moderates the pain system, and how to prescribe graded increases in activity. Dr. Andrea Furlan is a physician trained in Brazil. She's a specialist in physical medicine and rehabilitation. or physiatry. She obtained a PhD degree in clinical epidemiology at the University of Toronto. Currently, she's an associate professor in the Department of Medicine at the University of Toronto, a senior scientist at KITE, Toronto Rehab, UHN, and a scientist at the Institute for Work and Health. She's a chair of the ECHO Ontario Chronic Pain and Opioid Stewardship and co-chair of the ECHO Occupational Environmental Medicine, a pilot project funded by WSIB. She's a physician in the pain clinic at the Toronto Rehabilitation Institute, which is part of the Toronto Academic Pain Medicine Institute, or TAPMI. She is also a huge star on her YouTube channel, and we are so excited to have you. Thank you so much, Dr. Furlan.
Thank you very much. Thank you for inviting me to talk to your group tonight. It's my pleasure to be here. And let me just start sharing my slides. Let me see here. I know we did this before and it worked. Here. Screen 2. Can you give me some information if you are seeing my first slide?
Looks great. Here, all good.
Okay, thank you. Okay, so I'll be talking about activity, movement, exercise for people in pain. This is so important because it's one of the few things that we know work for chronic pain, and still not a lot of patients adhere to this, and not a lot of physicians, nurses, even physiotherapists are able to motivate patients to engage in activity, in physical exercise. So let's talk about that. In terms of, here. So you heard the learning objectives is to help patients understand when it's safe to begin an activity program, educate the patients the ways that activity moderate the pain system, and for you to prescribe graded increases in activity. My disclosures, I have some grants from Health Canada, CIHR, Ontario Ministry of Health, Canadian Generic Product Association, and the YouTube channel that is monetized. And no other financial disclosures, and this program is funded by, it receives in-kind support from Alberta College of Family Physicians. And all learning objectives have been developed by the planning committee and provided to me, and the presentations are reviewed by the planning committee prior to the presentation to ensure appropriate balance. Okay, so here we are. Activity and pain. It's hard to get some people to get off the couch and exercise, and even to vacuum their houses. Some people are more motivated than others. I have to tell you, I'm not. I am the one that I don't like exercising, and there are many reasons why some people don't like to exercise or don't do exercise. Some differences are genetic, or cultural, or familiar, or even environmental differences. But in our patients with chronic pain, there is a factor that is very important to motivate our patients with chronic pain to be physically active. Can you write in the chat your answers, what you think would be the barriers that your patients with chronic pain say that they don't exercise? And they say, don't tell me to exercise, don't tell me to move, I don't want to. What is it they say? And maybe Lori can read the chat or the Q&A. I don't know where they will be writing, but Lori, can you read for me some answers that people are typing?
Sure, yeah, go ahead and use the chat if you like. So it hurts, they try to avoid pain.
Okay, because it hurts. Okay, anything else? So yeah, that's a good one, and that's the main one that I want to tackle today. Now, does anyone know why it hurts when people do exercise, especially in people who have chronic pain? That's basically what we will see here today. When there is nociplastic pain, and I will explain to you what is nociplastic pain, exercises does not have the same perceived benefits as it does in people without nociplastic pain. So in a person that does not have nociplastic pain, when they do exercises, they may feel that, the 48 hours, 72 hours of delay onset muscle soreness, which is that pain that we feel in our muscles because you are exercising some muscles that were resting too long. And we all know that that's normal, but that's not what bothers people with chronic pain. Because people who don't have chronic pain, don't have nociplastic pain, they get a lot of releases of endorphins, they get the releases of endocannabinoids, and those are anti-inflammatory, those are pro-analgesic. But people who have nociplastic pain, they have the opposite response. So they're right when they tell you, I don't want to exercise because it hurts. It hurts, and they intuitively they know it hurts, but they don't do it. And there is a very, very dangerous pathway that then will spiral down and they will get much worse, including the nociplastic pain. So what is nociplastic pain? Does anyone here knows what is nociplastic pain? Okay, I'll talk about the 3 types of pain. And this, I didn't invent this. I just came last week. There was the World Congress of Pain, and the people who invented this classification are from the ISP, International Association for the Study of Pain. And I attended a session that people were debating this nomenclature, this class, but it's a classification that works really well. So the 3 types, these are mechanisms of pain. So what is nociceptive pain? So nociceptive pain mainly is, if you compare the pain system as the alarm system of a house, the alarm system of the house will go off when there is a fire, right? So if there is a fire in the kitchen, you want the alarm system to go off. So if there is something wrong, something broken, a fracture, an inflammation, a nerve injury, a nerve compression, or a appendicitis, you want the alarm system of the body to go off because you need to do something. That's pain. That's nociceptive pain, okay? What is neuropathic pain? Neuropathic pain is when there is some short circuits in the alarm system of the house, so you need to fix the wires. So examples of neuropathic pain is postherpetic neuralgia, multiple sclerosis, spinal cord injury, central post-stroke pain. And those things are neuropathic because, or carpal tunnel syndrome, because there is a compression of the median nerve at the wrist. So you need to go decompress the nerve, or if it's a postherpetic neuralgia or even herpes zoster, you treat with antiviral or antineuropathic pain medications. Now, what is nociplastic pain is when there is a change in the pain system, but everything is normal. So the kitchen has been renovated. So there might have been a fire many, many years ago that destroyed this kitchen. But now the kitchen is renovated, everything is working, but the person is not using the kitchen. Nociplastic pain means there was some sort of pain in the past that sometimes we don't even know. It was a nociceptive, a neuropathic, but that pain changed the pain system. And now the person doesn't want to use the body the same way that they used to use before. So I have a video in my YouTube channel that I explain exactly this, the 3 types of pain. So nociplastic pain, the definition by the International Association for the Study of Pain, this is how they define. It's pain that arises from altered nociception. So the key here is altered nociception. Despite no clear evidence of nociceptive pain, which is actual or threatened tissue damage causing the activation of peripheral nociceptors, or an evidence for disease, and there is no neuropathic pain because there is no lesion of the somatosensory system causing the pain. So you do your due diligence, you eliminate, it's not nociceptive, it's not neuropathic, and the person has some characteristics. The nociplastic pain has some specific characteristics. It doesn't confine to a part of the body. It may be widespread, it may be outside of the dermatomes. It has other symptoms that involve the brain, emotions, so mood, sleep, hypersensitivity to smells, all of those that we call central sensitization are part of the nociplastic pain. And if you ever seen a patient with fibromyalgia, you know what I'm talking about, because fibromyalgia is the poster child of nociplastic pain. So you do all your investigations, they don't have nociceptive, no neuropathic, what they have is nociplastic pain. And people with fibromyalgia, they are terrified about doing exercise because they know it's going to hurt. So what is pain? Again, pain is this impulse. So in the 16th century, René Descartes for the first time described that pain was something. Now we know it's an electrical impulse that goes from the area that is damaged to the brain. So he was the first one to connect that pain goes to the brain. But pain is more than that, because the brain is also able to activate descending inhibitory pathways. That's the green line coming down, and activate a lot of anti-nociceptive pathways. These are powerful endogenous opioids in the brainstem that are released, and they're also related to different areas of the brain cortex that are activated to modulate this pain. And again, in fibromyalgia patients, most of them are unable to activate these descending inhibitory pathways. That's one of the mechanisms of fibromyalgia. It's not the only one, but it's one of the mechanisms. So when we talk about central sensitization means this pain system involves all of the ascending pathways, the descending pathways, the areas of the emotion in the brain, the skin, the immune system, the hormonal system, because we will see here, even the HPA axis is abnormal, is sensitized. But the sensitization can happen at many different focus areas. It can be peripheral sensitization, central sensitization at the level of the spinal cord, and even cortical reorganization. So nociplastic pain, this is a great paper written by a Canadian rheumatologist, Dr. Fitzcharles. She published in The Lancet, and she talks about nociplastic pain in patients with rheumatology. It's not just fibromyalgia. A lot of patients who have osteoarthritis, rheumatoid arthritis, psoriatic arthritis, they may have their nociceptive component and a mixed component of nociplastic pain. Nobody said that a person can only choose one type of pain. They can have multiple mixed types of pain. And Mary Ellen Fitzcharles, she wrote about this. So I'll just show you a few papers, not a lot, because there are a lot of literature showing where this sensitization can happen. But what I'll show you today is the ones that are related to the fear of movement, the fear to exercise, because that's real. And if we don't understand why exercise is important to our patients, we will not be able to convince them. So what I'll give you today is some arguments, some evidence that you can show to your patients and explain to them that exercise is the pathway for them to revert nociplastic pain. Okay, so bear with me. This looks complicated. It's even complicated to me, but this is an amazing study. These two researchers, Catherine Bushnell was last week at the ISP conference. I and Laurie, we attended in Toronto, and I even have a picture with Kathy Bushnell. She's the president-elect of ISP. She's Canadian, but now she's working at the NIH because she's investigating changes in the brain that happen with exercise, yoga, meditation, hypnosis. Okay, so let me show you, what is this? This is the insula. If you don't remember neuroscience, this is a tiny part of the brain, right in the middle of the brain. Insula, we have the anterior. This is the anterior, the green here is the anterior insula, and the blue is the posterior insula. These dots represent studies that were done with people with pain and people who don't have pain. So normal volunteers who don't have any chronic pain, they don't have pain. If you provoke pain on them, all the dots are activated in the posterior insula. Okay, the purple dots here are the posterior insula. Now, if you have someone who is living with chronic pain and you provoke pain, guess what? They are the black dots. They activate the anterior insula. This other figure here is a meta-analysis of all the studies that did this kind of a replication of study, and they show the same thing. There's a very clear demarcation. The purple, which are normal people without nociplastic pain, no history of chronic pain, they activate the posterior. And people with chronic pain, they activate the anterior insula. But guess what? Other conditions are also activated in the anterior insula. And those are things like the red dot is mainly a non-painful stimulus with highly aversive content. So if you show someone a highly aversive picture or a history, and they will activate the anterior insula. If you, if you want to show also things that are very aggressive, like very emotional, very sad, those are the blue dots. They activate the anterior insula. The yellow dot here are all the studies that looked at interoception. Interoception is how much you perceive your internal organs, how much you perceive your own body. So you see, people with chronic pain, they activate different areas of the brain. So how can we shift their sensations to the posterior insula? And this is only one area that is abnormal. There are so many, I don't have time to explain to you all the other changes that happen in people with nociplastic pain and chronic pain. This is just possible because in the last 20 years, we have developed a lot of imaging studies that we can study the brain, the spinal cord, the brainstem with imaging, and we can see these things because before we didn't know. This is another study. They showed these dots here are areas of atrophy. Atrophy in the insula, atrophy in the anterior cingulate cortex. Atrophy, look at how many points of atrophy in the prefrontal cortex in people with chronic pain. They do have even though the difference is not huge, it's about 3%, 5% less than their age and sex matched controls. A 5% reduction in your brain size is a big reduction, is a big atrophy of brain gray matter. And that's why a lot of our patients with chronic pain, they say that they have this brain fog. It's difficult for them to concentrate, to remember instructions, to work, and to carry their normal lives. So the nociplastic brain is associated with reductions in the brain gray matter volume, as I showed you, also disruptions in the white matter integrity, and alterations in the neurocircuitry that resembles those seen in neurodegenerative diseases. So sometimes when you do even cognitive tests in a person with chronic pain, in a person with dementia, you don't know the difference. They may have similar features. And neurodegenerative diseases show up with white matter and neurocircuitry problems and chronic pain too. So they're making, and the name nociplastic pain, noci is pain, plastic is neuroplasticity. What happens is neurons that fire together, they wire together. So you are creating synapses everywhere in the brain, brainstem, spinal cord. And are they reversible? We'll see. Not all of them, unfortunately. So this is what Catherine Bushnell is doing. She's investigating the use of yoga as a mind-body practice because it involves concentration mind exercises, respiratory breathing exercises, and physical exercise. So the three together you can find in yoga practices and many other practices as well. they do the opposite in the brain circuitry. So when you get someone and starts practicing yoga, they start reverting all of those neuroplasticity changes in the brain. But that's not the only thing that changes in the brain. The HPA axis is also affected in a person with chronic pain from nociplastic origin. This paper by Eller Smith, published in 2018, is a great summary if you want to read all of these changes. So what happens, I'll explain this to you. This is an acute normal situation. So if in normal conditions, when a person goes through an acute stressor, what happens? They will activate the areas of the paraventricular nucleus in the brain, and that will then stimulate the hypothalamus to release CRF. And then the CRF will go into the hypophyseal portal veins and cause the pituitary gland to release ACTH. And what? The ACTH will go to the adrenal gland and release glucocorticoids, right? This is a normal stress response. Also, from the hypothalamus, it will activate mast cells. So here's where the immune system is involved. So here we see the endocrine immune system also being in a balance. It will go to the spinal cord and make the mast cells activated, and then you see the pain system. You remember the arrow going up and arrow going down. They are in balance, and the person will not feel pain. However, in a sensitized condition, and this could be chronic stress or early life stress. We all heard about adverse childhood experiences, ACEs, that cause imbalances in the HPA axis. And look, if a person is suffering currently chronic stress, or they had stress during their early childhood, all of this, the balance is lost. So let's see a little bit what's happening here. So the first thing here is the CRF is driving from the amygdala. The amygdala is very important in stressful situations. It's the center of stress. We see this with functional MRIs. When a person is under stress, the amygdala lights up. There's even hypertrophy of the amygdala. We have two amygdalas in the brain, right and left, and they control the hypothalamus. And the hippocampus here is supposed to block, to inhibit this cascade of stress. But it's not. It's unable because the hippocampus is not functioning well and the amygdala is super active. Guess what? It's a lot of flush of glucocorticoids, a lot of impulse sent to the mast cells in the spinal cord, and that will also, remember the descending inhibitory pathways that inhibit pain coming from the brain? What are happening to them? They're eliminated, right? You see the arrow going up, the pain going up, but now you have an inability to block the descending pathways of pain. So the person under stress, which is totally reversed from what happens in normal life. In normal situations, when a person does not have sensitization, stress is analgesic. You might remember stories of people who were in the war, they were amputated, they didn't even feel pain because they were under stress. Yes, that's what a normal brain will do. A lot of adrenaline, glucocorticoid will block pain, not in a sensitized brain. In a sensitized brain, stress will provoke more pain. And how do you revert that? Guess what? The two things that we know at this point, there's no medication, no injection, nothing. But the green here is what? Exercise. And the purple is cognitive behavioral therapy. Those are the two only things. Again, mind, body, and physical exercise are the two things that we know that when they work together, they promote a balance again of this HPA axis, the mast cells go to normal, and you start seeing the activity of the descending inhibitory pathway. So again, exercise and mind-body therapy. So I tell my patients, I usually tell them, I don't have a medication to cure your nociplastic pain. I think that's what you have, but you can do a lot for yourself if you do exercise for your mind and exercise for your body. And then I work with them on a program that I'll show to you what I do with them. So a little bit of central sensitization in the spinal cord. This is the synapses that is bringing in painful impulses from the periphery. Here it's bringing a nociceptive impulse to the synapses in the spinal cord. This is the dorsal horn of the spinal cord. This synapse is normal. It's releasing neurotransmitters. The neurotransmitters will activate the postsynaptic neuron that will go to the brain. And the brain will activate, send messages down, and will activate this inhibitory neuron here. And this inhibitory neuron will have the capacity to block these synapses. In acute phases of central sensitization, what happens is you get one impulse coming from the periphery, but you have a lot of neurotransmitters now because this synapse is hypersensitive. You see how a lot of neurotransmitters here are released, including the glutamate, NMDA receptors are opened. Normally the NMDA receptors are blocked by magnesium, but now they're opened. What happens when an NMDA receptor is opened and receives glutamate? It amplifies the pain sensation. So this person here that is receiving pain from the periphery is feeling pain amplified in the brain because the NMDA receptor here is active. The volume is turned up. And guess what opioids do? Opioids, if you put opioids to this person here, if you give opioids to this person, opioid will activate these NMDA receptors and will do the same thing that glutamate does, will just increase the volume of pain. And that's what we call opioid-induced hyperalgesia. This is the acute phase of central sensitization, but in the late phase of central sensitization, look, you don't even need the nociceptive impulse anymore. There's no more pain in the periphery. The fracture, the inflammation, the tendinitis has healed. But you see the synapse continues active and keeps activating itself. This is the late phase of central sensitization in the spinal cord. But the good thing is that we still have the ability of the interneuron, the inhibitory interneuron, until we lose that ability. In the late phases of central sensitization, you lose the ability to inhibit this synapse, unfortunately. So this is how I explain to patients. Normal pain is the first one. Let's say you get 3 impulses, you broke your bone, and you get 3 impulses, electrical impulses, and your pain system is normal, and then there are 3 impulses that go to the brain. Okay, everything is normal. In the next phase of sensitization, you have a modulation, which means you're getting nociception, like 3, but your brain is receiving 5. So this is called modulation, and it's the early stage of sensitization. The late stage of sensitization is when you don't need more nociception. There's no more. You don't have that. But your brain is still receiving 5 messages of pain. But now there is a short circuit there because other sensations will be able to activate your pain system. Do you know what are these other sensations? Movement. So proprioception, when they move, when they exercise, now that sensation, it's proprioception. When you touch the skin, that is allodynia. When they have a little bit of pain, they have hyperesthesia. They are hypersensitive. And they don't need to have pain anymore. It's not nociceptive. It's just normal sensation, but their brain is interpreting that as pain. So imagine you do exercise and your brain is feeling pain. And then for days and weeks after you do that exercise, you still have pain. They don't want to do exercise. Natural, right? I would not want to do exercise. Naturally, they know that they have to stop doing exercise. There are also gene expression modifications. And so unfortunately, when this happens, it's almost irreversible. We don't know if this is reversible or not, because when there is gene expression in the modification, Can you revert back to what it was before? We don't know yet. But Catherine Bushnell, she's very hopeful that she thinks that it is reversible because she's seen those in human brains that they are able to revert, even the brain atrophy. A couple of years ago, she showed the studies that she did. She was able to revert the brain atrophy with exercise. So I also have a video that I explain to patients what is central sensitization. I also talk about pain as an illusion because they have those sensations of, they feel these weird sensations, and I call that pain illusions. Okay, let's talk a little bit about physical exercises. So how does physical exercise reduce central sensitization? I think the first thing, before I explain to you the recipe of physical exercise, one thing that is important is for people with chronic pain, if they do a burst of exercise, let's say they go to the gym or they decide to clean the whole house, it will not help. Okay, it will not help. It will actually cause more pain, and it will not fix the pain system. The way that exercises work for fixing the pain system is if they do small chunks, but regularly. Okay? Keep this in mind. Small chunks, regularly, start increasing gradually. If they try to do all their exercises at once, they're going to do more damage than good. So how does physical exercise reduce central sensitization? So the glial cells secrete fewer inflammatory cytokines. There is less sensitization and excitation of nociceptive neurons of the dorsal horn, less sensitization of the supraspinal pain processing centers, and less branching of nociceptor, the peptides. So this is all complicated to me, but this comes from animal studies. That's why I put the mini mouse here. This is all good, but this is all shown in animals, in laboratory. How about humans? Does it happen? Do we have the same things in humans? We're going to see. The other thing that also exercises does in animal models is that it prevents central sensitization. So if you have a patient that you are suspecting that they are transitioning from nociceptive to nociplastic or neuropathic to nociplastic, it's good to do a very good exercise program to prevent their central sensitization. And this was done with animals. Actually, this was a very interesting study. They put this mouse in a running wheel exercise, and they showed that they prevented hyperalgesia and had therapeutic and preventive effects on inflammatory stimulus-induced persistent hyperalgesia. And it was bypassed the placebo effects bias. So it really prevents chronic pain. Not only treats central sensitization, reverts, but also prevents it. So an important thing is a lot of our patients, when we ask them to exercise and reduce their weight, they think that we are interested only in their metabolic syndrome to prevent diabetes, cardiovascular problems. It's much more than that. More recently, in the last, I think in the last 20 years, the field has advanced so much. I don't know if you heard about adipokines, but adipokines are more than 100. There are more than 100 adipokines that are released by fat tissue in our body. And adipokines are pro-inflammatory. So if a person loses weight by diet and exercise, guess what? They will also produce less adipokines and they will have less pain. Actually, this is the main mechanism that they are talking now about osteoarthritis. We know that people who are obese, they have more osteoarthritis in the knees, hips, but they also have more osteoarthritis in the hands and elbows and shoulders. It's not just related to the amount of weight that they carry in the joints, but it's a lot related to the pro-inflammatory state that these adipokines release. And exercise is the method to avoid anything that can reduce fat tissue in the body will reduce adipokines. So this is just a summary to say that chronic pain is very complex. It's not easy. And there is this nociception in the terminal organ. This terminal organ can be the skin, can be the joint, can be the muscle, the bone, can be an internal organ, can be an internal tendon or things that we don't see, we don't know where they are. But there are a lot of things that can happen at the nociceptor level, but also at the spinal cord level with central sensitization. We saw neuroimmune transformations and modifications. We saw that the descending inhibitory pathway can be abnormal, may not be functioning the way it was supposed to function. We know that there are all those cortical plasticity that involves a lot of emotions and fear at the amygdala and stress, and then the consequences is sleep problems, mood problems, and these patients are seen as very complex patients because they are stressed and they have problems concentrating, and we want them to exercise. So how do we do that? So let's talk now about how do we educate a patient about the ways that activity moderates the pain system and how we prescribe a graded increase in activity. So I read some papers from many wonderful physiotherapists, and they're calling for a time for change. A time for change in how we see exercise. So here, so here is a physiotherapist and a person. Probably, let's imagine that this lady has chronic pain. So what is he telling her? What are the messages that he is saying to her when she's doing exercise? Where is he focusing his attention? Is he focusing his attention in let's gain the range of motion from 89 degrees to 90 degrees? Or is he focusing his attention on her brain, her pain system? What is she thinking? What is the message that she's receiving? Is she here doing the exercise just because she's thinking, I need to get stronger, I need to get more flexible, I need to improve my balance? Or is she thinking, I have chronic pain and I need to retrain my pain system? That is the change that we need to have as soon as possible, because if we don't change that, we'll keep doing exercises to improve the range of motion from 90 degrees to 89 or 89 to 90, but we will not fix the pain system. So these two people, Lorimer Mosley and Joe Neese, indulge in their materials. If you can Google them, read everything they write, they publish a lot. They are two physiotherapists. Lorimer is from Australia. Joe Neese is from Denmark. Yeah, I think it's from Denmark. Unfortunately, they did not come to the ISP conference last week, but they are usually there giving big plenary sessions. They are amazing. They are the ones who are trying to change this field of physiotherapy. And why is that? So the treatment of people with chronic pain, when central sensitization is involved, we need to prescribe and provide pain neuroscience education. But people with chronic pain, they don't want to go to a school to learn about these things. How is my brain being affected by pain? The physiotherapist is spending time with them, an hour of exercise. If the physiotherapist, occupational therapist, chiropractor, whoever that is doing exercise with them knows pain neuroscience education, they can deliver that right there. There is no evidence that tricyclic antidepressants, SNRIs reverse central sensitization. And we need to focus on the long-term effects of these people. And we need to address central sensitization, the stress in their life, the sleep problem, physical inactivity, the nutrition, and maladaptive cognitions. I have a video that I tackle the problem of maladaptive cognition, because when the patient thinks they have the disc bulge and that is all that is causing their pain, they are not ready to listen. Oh, I have to do exercise for my mind and exercise for my body. I need, nobody will fix me. But they are fixated on that disc bulge. So I have a video that I show MRI of people without back pain. Here, nobody had back pain, but look, older individuals had 96% had some form of disc degeneration. Even younger children, 37% had some form of disc degeneration. Disc bulge, children have 30% disc bulge. Older adults, 84%. Disc protrusion, children, asymptomatic, they don't have any back pain. 29% of children have disc protrusion, 43% of older adults. So we need to stop blaming that thing on the MRI, on the X-ray, on the body, unless if they really have, if you can correlate the physical signs, the pain, and the MRI, perfect. Okay, it's a nociceptive or neuropathic pain. But when it's not, don't blame on something that, and stop ordering MRIs because they will come abnormal. There are randomized trials showing that pain neuroscience education works. There are these are good quality randomized trials in people, real people, that face-to-face sessions of pain neuroscience education are required to change inappropriate cognitions and perceived health in patients with fibromyalgia. That pain physiology education seems to be a useful component in the treatment of fibromyalgia patients, as it improves health status and endogenous pain inhibition in the long term. And there was no between group differences found for fatigue, sleep disturbances, and the rest of the tests in the senior fitness test. These results suggest that pain neuroscience education and the TE, which was, I forgot what was TE, was more effective than, it was exercise. So pain neuroscience education plus a type of exercise was more effective than just exercise in isolation. So when you send your patients to a physical therapist or someone that will move their body, ask them, are you assessing the patient's maladaptive coping mechanisms and cognition? If they say, oh, what? I don't even know what you're talking about, don't send your patients to them. They don't know pain neuroscience education. You can ask them, do you employ a bottom-up or top-down approach? So you want them, instead of being working on the muscles, you want them to work on the brain, and the brain will control the muscles. So you want a top-down approach. Are they able to explain to your patients how exercise targets the central nervous system? Are they able to focus on long-term improvements rather than short-term effects? Are they monitoring progression towards functional goals? So some key teaching points here. Nociplastic pain is real. It's not invented. The patient is not inventing the pain. It's not imaginary pain. It's real. It's constant. It's very annoying, and the volume is turned up. So it's very intense. Central sensitization feels like severe pain, tiring pain, constant pain, spreading pain, numbness, and heaviness. And you have to demonstrate that you believe your patients. Otherwise, they will not trust you and they will not follow what you're saying. Healthcare professionals have little training about nociplastic pain. Therefore, patients are frustrated that nobody knows what they have. And pain is felt in the absence of tissue damage. So pain is not a sign of danger anymore. It is okay to do activities, even if it hurts. Your brain will learn that they are not harmful, and the sensations of pain will diminish over time. So these are messages that you have to give to your patients, and the physiotherapist has to give to their patients, to your patients. So how do you program like a graded activity plan? First, focus on the therapeutic alliance. Does your patient trust you, that you know what you're talking about? Second, initiate more active lifestyle intervention, include stress management and sleep efficiency strategies, use guided imagery, sensory motor retraining, graded activity program, or graded exposure program. There are different types of exercises. Aerobic exercises or cardio endurance exercises, they elevate the heart rate, respiratory rate. They're great for improving the cardiorespiratory system. They have a therapeutic window and worsening of pain if too intense. So tell your patients not to go too much on the aerobic exercise or they will feel a lot of pain. And especially if they have delayed onset muscle soreness or DOMS. What about resistance and strength training? They can use weights. They can do many sets, many repetitions. It's not a problem. They have to start with very, light weights and progress gradually to more weights as they can tolerate. There are few studies of resistance strength training in chronic pain, and we recommend isometric or isotonic contractions. And I also have a video that I show how people with fibromyalgia, they can progress. So there's 4 months of progression, what they can do month 1, month 2, month 3, month 4, and they can download this spreadsheet from a link that I have in my video. And I also have demonstrations of me doing these exercises for people with fibromyalgia and many other types of chronic pain. So I guess that's the end. We covered all the learning objectives. My videos have subtitles in 44 languages. So if you have patients that do not understand English well, which is the problem here in Toronto, the reason that I do this is because many of my patients do not understand English very well. So I put closed captions for them. And that's it. Thank you very much.
Fantastic. Thank you so much, Dr. Furlan. That was excellent. So we have a couple of questions. So I'll start with possibly the one that you could talk for another hour on, which is what determines who will get central sensitization or not?
Yeah, I could talk about it. I have a video about that too, because I got a question in my channel. There are a few things that we know predispose a person to central sensitization. Stressors, chronic stressors, recent or early childhood, adverse childhood experiences predispose the brain to central sensitization. So acute stressors, it also depends on what was the situation that the person started having their pain. So if the pain started, nociceptive or neuropathic, when, let's say, they were playing soccer with their kids, nobody was at fault, and let's say they broke their fibula, they probably will heal okay. But if that fibula breaks because someone was at fault, like could be a car accident, a bicycle, motorcycle, and someone hit them, someone was guilty, and now they have a lawyer on top. So all of that stress in their brain can predispose the brain to create nociplastic pain. So always ask your patients if they remember when the pain started. Sometimes they don't. Or you can ask them, do you notice some things, your memories, some memories that you have that make your pain more intense? Because if they do realize that the pain started at a moment of their life that was very stressful, or even if they had ACEs when they were kids, they had adverse childhood experiences, they were okay during childhood, but then later in life they start having chronic pain, they need some psychological therapy to help them to resolve those stressors in their life.
Excellent. The complications pile on top of complications sometimes. There's a question here that is a common question for those of us who are trying to design services or improve services, particularly in primary care. Have there been studies on pain neuroscience education in a group setting versus one-to-one with a rehab specialist? Is there any evidence that one is more effective than the other?
I can't remember right now if there are in group sessions. I can take a look for you. I'm pretty sure there are studies looking at a virtual delivery of care, because during the pandemic, a lot of the services were also blocked because of the pandemic, that they couldn't do face-to-face. And I didn't do a systematic review of pain neuroscience education, but the field is advancing very quick. A lot of physiotherapists are now investing on this. Not only them, but chiropractors, occupational therapists, personal trainers are learning about this. and learning about the messages that they have to give. So again, if you want to know what is new, just follow Jonice and Lorimer Mosley, and they whatever they publish, I just indulge on all of their publications.
So I've posted a couple of links in the chat. Just one of them is a podcast that Jonice does called Healing Pain. And then also Laura Mosley's Tame the Beast website I posted in the chat. So you can have a look at those. So on that note, actually, there's a question about, you mentioned ask the physiotherapist if they are what their approach is, and if you get the wrong answer, don't send the patient there. So what if, and particularly for some of our providers who are in more remote or rural locations, what if you have a physio that you work really well with and would like to maintain that relationship? How can you sort of start a conversation or steer them in the direction of learning more about this and still maintain the relationship with them?
I was just being a little dramatic. I like being a little dramatic. Yeah, of course, you're not going to fire them. I think the best approach is let's study together. Let's read some papers together and show the physiotherapist that there is evidence that this works. Me too. I have some physiotherapists, wonderful, who work with me, but they are not so versed in the pain neuroscience education. They don't know much because the field is advancing so quick. But I tell them, let's learn together, let's do some journal clubs, and can you incorporate some of this in your talks to my patients? Because I think they have nociplastic pain.
That's a good suggestion. So a question here about what are your thoughts about aquatic therapies or pool-based therapies?
I love aquatic therapy. The problem is some patients don't have access to, or they don't like water, they are allergic to chlorine. They have all kinds of excuses, but I tell them if they can do, especially there are some aqua therapy that involves music and like hydrogymnastics. That's also good for the mind, for distraction. They socialize, which is another aspect of reducing sensory sensation, is when they socialize, they see other people, they talk to other people. And the water offers a lot of benefits. It offers resistance, but you'll be doing resistance exercise. Also, because you have to move the water, you'll be doing more cardio exercises. And also the temperature of the water can relax the muscles if the water is a little warm. So whenever they can afford or they have a pool and they like it, I highly recommend them to do it, 2 or 3 times a week. I had a patient that I think she was 85 years old, osteoarthritis everywhere. And I told her if she could find a pool, and then she came back to me just to say thank you. Her daughter bought a spa, one of those, the daughter installed outside of her kitchen, and she goes twice a day, 6 o'clock in the morning, 6 o'clock in the evening, except Sunday morning that she doesn't go. And she said, Dr. Furlan, my pains, all of them disappeared. But twice a day, and for 1 hour, she was in the spa walking and exercising and moving. And the daughter said that she had to be in the kitchen watching her mom, so she would not faint or fall or do anything. And but all of her pains disappeared.
That is quite the accommodation. So there's that actually leads to one of the other questions in our list, which is, will they ever be pain-free? Do you tell patients that
I never
if they
lose
exercise?
hope. Yeah, I never lose. I think they need to have their hope. I think we cannot steal their hope. If they ask me, even if I have the faint hope, I will tell them, yes, I think you will be pain-free, because I really think, even if there's a 1% chance, that's all they need, that 1%. Most people would take some time for them to be pain-free, but I think what they discover is that they will not go back to their previous state. I think once they realize that their life will never be the same as it was before, but they can live well, they can have a good quality of life. They don't need to live in misery, in suffering. because mind, body, socialization, losing weight, sleeping well gives a tremendous quality of life. And they tell that the pain doesn't bother them anymore. So I tell them, I don't know if you'll be pain free. And this is what I explain to them, Lori. I tell them, this is your pain and this is your life. And your pain is occupying almost everything of your life. And I can try to give you injections and medications and blocks to bring the pain from here to here. But with these other measures, I'm improving the person that has pain, and the sky is the limit. So even if your pain is fluctuating here, this can be so high and your pain will not influence your life that much. I think they see that and they realize that if they improve themselves, the pain has a much less role in their life. That's what I see. You probably see this a lot in your clients that are successful. It's not because their pain disappears, because they're understanding their pain better. They're not chasing that magic pill. They are on much less medications, and they are taking care of themselves. They have a toolbox full of tools, including exercises, mind, body, nutrition, and taking care of themselves.
Mhm. Yeah, I think that's one of Lorimer Mosley's key messages now, that, we used to tell people that chronic pain is chronic. Now that you have it, you're going to have pain forever. But, one of the key messages now is that pain is really complex and there are a lot of things feeding into it. But that means there are a lot of things that we can do to impact how your pain, what your pain experience is.
Yeah.
So one of the questions here was, one of our kind of truisms in talking about exercise with patients is the best exercise is the one that they will do.
Yeah.
So starting where the patient is at, what do they want to do? What do they have access to? If they hate being in a swimsuit, then pool exercises are probably not the thing. But so if your patient has no preference between cardio exercise and resistance exercise, they have equal access to both, is there any evidence that you should start with one over the other in terms of benefits?
No, for pain retraining, strength exercise actually is good. Resistance, flexibility. So many years ago, we used to say fibromyalgia patients need to do stretching. I still tell them to do stretching because everybody needs a little bit of stretch, except hypermobile people. they can dislocate their joints if they do too much stretch. But aerobics, resistance, and a little bit stretch is where I would start. A little bit of each, see which ones they like, try different things. And I tell them, start walking. Even if you have stairs at home, try to do, I have a video that I show what kind of exercise you can do in the stairs, going with one leg, another leg going down. They don't think that stair exercise is like a gym, but it is. And as long as, as you said, as long as they do, they adhere, that's what is important.
Tina, I wonder if I can unmute you. Hang on, so that you could maybe ask your question. Can I do this? Will that work? Are you allowed to talk now?
Hi, can you hear me?
We can.
Thank you. Thank you, Dr. Furlan. It's always excellent to hear you teach. I was just wondering if you can help clarify and help with the nuances of explaining to patients. I sometimes feel that patients, when they hear pain-free or they want to have no pain, that their expectation is they'll never, ever have any pain ever again. So how do we instill the hope that you talk about without giving them the unrealistic expectation that, when they slam their knee into a table at some point, that they'll never have pain? So it's just, to me, a little bit of a fine line. So
Yeah.
can you speak to that?
It's interesting that there are some people, even with fibromyalgia, I know a couple of patients and even people in my family, they don't have pain. they had fibromyalgia, they don't have pain, but they continue doing the exercises and the things that they know how to do, not gaining weight. And if you ask them, they say, no, I don't feel more pain. But if I stop doing those things, I know the pain will come back. If I sleep, less hours or more hours than I should, I know I'll have a headache the next day. So it might be possible that some people will have good days, bad days. Migraine is a type of nociplastic pain. We now know that migraine is a type of primary pain. In primary pain, the mechanism is nociplastic. And we know migraines, you have good days and bad days. So the idea is chronic pain is a chronic disease. You will have to control it for the rest of your life. There will be days that you will be pain-free, and there will be days that you have a flare, but you need to know what do you do when you have a flare-up and bring back your steady state. And they say, even if I have a pain that is like a 2 out of 10 or 3 out of 10, I can live with that. So even some people, they will never be pain-free, but they are very happy if the pain is only in the background. And they may realize the things that trigger that flare up, like physical stress, lack of sleep, or too much physical activity, or some mental stress that they have, or problems. And at least they know what caused. The problem is when they don't know and they get despaired. What is this? Is it cancer? Is it my disc that was bulged and now it's ruptured and I need surgery in my back? And then they start catastrophizing. And catastrophization is one of the predictors of perpetuation of chronic pain. If the thoughts that they have in their heads are going down spiral, I'll get worse and worse and worse and worse and worse. Guess what? They will get worse because their mind is not in the healing state. It's more concentrated on what is wrong and the danger. What is the danger here? So yeah, there is a book that I read recently. What I have here? I don't know if you read this book. Let me see. Did you guys read this book?
I've seen that book.
Yeah, I read this book, and this guy who wrote this book, he cured himself of his chronic back pain by doing brain pain reprocessing therapy, and now he teaches others, and he teaches in the book. And the other day I gave to one of my, I tell my patients now to either buy the book and read, or download the audiobook and listen. I had a patient, 35 years old, male, very debilitated by pain, but still he's working and he's very motivated. He listened to the audiobook and he came to me and he said, after 2 years, I don't have more pain. Pain disappeared. So I don't know if the pain will come back. Maybe the pain is still there. Those changes are still there. He's just able to control. Actually, he came to me. I said to him, why did you come? I was curious to see, because usually patients, when they get better, they don't come for follow-up. He said, because I'm afraid that the pain will come back. And what should I do? Should I read the book again? He said, should I be listening to the book again if the pain comes back?
I'm just gonna post a link in the chat to the info on the book so that people can see that. Okay, so I'm getting drunk on the power of unmuting people and letting them actually ask their question for themselves. So Marsha, did you want to come off mute and ask your question?
Sure. Thank you so much for the opportunity. So I'm a family doctor in Calgary. And so my question was, as primary care providers, how do we best advocate for the importance of things like physiotherapy and exercise as a covered service in our healthcare system? Have you made any progress in your region with getting traction on this in terms of a cost benefit analysis?
No, unfortunately, I have the same problem in here in Ontario. Psychology, mental health, and physiotherapy only for people who have benefits or workers' compensation. Other than that, they get a little bit from the government, but the quality is mediocre.
Do you feel like there's any potential in the pain task force work and the follow-up?
Oh, yeah, absolutely. Absolutely. And that's why I started doing the videos, Lori, because I was so disappointed with what my patients were hearing and receiving in the community. So I did that for my patients, but it's not enough, of course, because it's nothing like, you have a person or a group, even a group session with a physiotherapist teaching that is better than nothing.
There was Health Canada struck a pain task force over the last couple of years I think it was 3 years, wasn't it? To look at stakeholder interviews and research across the country to look at what was needed for people to improve care for people with pain. And so the task force just wrapped up its work and presented a report with recommendations. And really the thread running through almost all of it is better access to physiotherapy, psychology, occupational therapy, and those kinds of things. So Health Canada has actually committed to funding for some projects across the country that will look at whether or not there's a sustainable model for that. So like in Alberta, a million years ago, physiotherapy was funded. And the problem was that what was happening was just a lot of passive therapies. People were getting 30 or 40 or 50 or 70 sessions with a physiotherapist who was just doing heat and ultrasound and TENS and not doing active therapies.
Yes.
So I don't know, in Ontario, are there models within primary care or, as part of the provincial work, are there models for a limited number of sessions of active physiotherapy?
Not that I know. And when I do the sessions of echo, I hear from our echo participants in primary care that they have the same difficulty, how to find high quality physiotherapy.
One of the things that we're doing in Calgary Zone is trying to work with the primary care networks to develop multidisciplinary teams. In each one, there are 5 of the 7 that have primary care based multidisciplinary teams for people with pain. So,
Again, for people who have private insurance, motor vehicle accidents, or workers' compensation, they get more sessions. But I also don't know, Laura, if they get high quality physiotherapy, because even some people in the motor vehicle insurance system, I asked them, what did you receive? And it was not ideal.
Yeah. How do you talk to patients about those passive therapies, the role that those things might play? Because lots of patients will say, I feel better when I get the TENS, or I feel better when I get the heat and the ultrasound. How do you talk to them about the role that plays?
So yeah, I tell them, you buy the machine, the TENS machine, you bring home, and then you apply 20 minutes, and then you do your exercises. It's just to release a little bit of endorphins in your system so you can do the exercise. But don't go there, spend your time and money receiving those things there. If maximum, maybe 10 minutes just to alleviate some tension, but you need to spend time doing the exercises and talking. The physiotherapist needs to be talking to you about what they are doing. But again, it's a new concept. Pain neuroscience education is a new concept. I think it's starting to penetrate in regular physiotherapy.
It's true. Well, we are now out of time, and I really, really appreciate the time that you've taken to talk to us about this, and you are definitely a national expert on this. So maybe what we should do also is just post a link in the chat to your YouTube channel.
Mm-hmm. Thank you.
I had it here, and then I put it down to find oh, there we go.